Hello and welcome to another Piper Pearl. Today's Pearl, we're going to be looking at the abdominal examination. It's a very common thing to perform when you're doing a patient consultation for pretty much anything involving respiratory problems, abdominal problems, genitourinary problems, and obviously pelvic floor as well. So over the years, you may have developed a few hints, a few tricks, but unfortunately, there's a lot of misinformation and it can be difficult to get a systematic approach that best suits the patient that we're dealing with. And sometimes doing a proper abdominal examination in some of the environments you work in can also be quite difficult. Today, we're going to focus on the aspects of the clinical examination and just offer a few tips and tricks to make it a little bit easier for us in some of the areas that we have to play in. So just starting off, we'll have a look at the abdominal regions again. So remember, whenever doing a primary healthcare examination as opposed to dealing with an emergency or trauma, it's best to use the 9 regions of the abdomen when describing your findings. The abdominal exam will generally cover everything from the nipples all the way down to the pubic line. Now, technically, it should go all the way down to the knees, but in order for patient comfort and realistically, there's not a lot to look at below the pelvic line, unless, of course, it's indicated, which we'll get into. So, of particular note, I want you to understand how small the lungs are in relation to the actual abdominal cavity. So, a lot of people don't realize, and it's partly due to the way that anatomy books are written, and when you're looking at the lungs, they are often enlarged in order to show the shape and the structures, but they actually only come down to basically just below the 4th and sometimes 5th intercostal space, which realistically is one hand underneath your armpit. So if you were to get your hand sticking underneath your arm, generally speaking, the base of where your pinky finger is where your lobes of your lungs will pretty much end and the abdominal cavity will start. So there's certain organs like your liver and your spleen that are quite difficult to palpate and find unless they're in a pathological state because they're found underneath the actual rib cage. Another area to note is in the right iliac margin with the umbilical and the hypogastric area, and that's your iliosacral area. And that's the best spot to actually listen to when you're doing auscultation. Other than that, just take a mental note of where the positions lie. Okay, with the descending colon coming down on the left side, the liver is on the right, the spleen is on the left, stomach's generally in the middle, and the gallbladder sits in the actual arch of the rib cage on the right hand side. So when you're getting started with an abdominal examination, it is all about the position. Now, all the recommendations out there will say that they want the person in the supine position. That's the best way to do an abdominal exam. The patient may be comfortable in what's known as the semi-supine, which is denoted by the picture on the right, with the patient lying flat, knees up, can take a little bit of pressure off their back and their abdominal muscles. So this is particularly the case when you're dealing with somebody who has lordosis or a curved pelvis, that lying flat may actually put increased strain on the person's abdomen. The goal is you want to put the person in a position where their abdominal muscles are not contracted. So generally speaking, that is in the supine position with your hands down by your side. If your pillow or thing underneath the head is too high, it will actually cause the abdominal cavity to contract. And if the person has a sacral problem or a lower back problem, the tilt of their pelvis is in the wrong direction, it can actually cause undue pain and discomfort to be in this position. So sometimes you'll need to position something underneath their knees, underneath their thighs, underneath their head, in order to get their comfort level set. When they're comfortable, they're not going to complain about pain, before you've even started the examination. Another thing to take into account is when we're in the field, a lot of the time our stretchers aren't really conducive with an abdominal exam. Most of the time because our patients are too big for the stretcher and it causes their shoulders and everything to hang over the side, which means they'll have to move in order to be comfortable, which puts pressure and contraction on their abdominal muscles. So sometimes it's best to actually lie the patient on the ground and put them in a position where their abdomen isn't actually contracted. Now, if you have obese patients, a lot of the time the physical examination of the abdomen is going to be difficult. Percussion's pretty much pointless. Auscultation is impossible, and palpation requires a huge amount of effort. So just take that into account. But what a lot of people don't actually appreciate is when you have the other end of the spectrum and you have an incredibly fit and toned person, a clinical examination can be difficult as well because you'll have general guarding or tone of the abdominal muscles throughout. So it's hard to denote the difference between what is guarding and what is actual just muscular tone. So just be aware that during palpation, you may need to look at other signs of discomfort like grimacing and pain on the patient's face, particularly if they are quite toned. Okay, moving right along, we'll start with the first thing we do in order of the abdominal examination, which is inspection. Now, when you research inspection and you research all the things to do with abdominal examination, a lot of the findings that you'll have that sit under inspection category really indicate quite significant problems. And I'll summarize some of the signs at the end of the lesson. But the biggest point is when you're dealing with a abdominal condition or someone comes in with an acute abdomen or pain in the area, it's best to have a look at the patient themselves and have a look at the patient's skin. So as they're moving around trying to get into a position that you ask them to, just look for signs of discomfort. See if the contraction of those muscles and the movement is actually causing more pain or difficulty for that patient to get into. When they're in position and they're supine and you've got them prepared so their chest exposed, then have a look at the way they breathe. Now, generally speaking, males and children will breathe from their abdomen, whereas females will breathe from their thorax, a more apexual breathing. But as people are breathing in, you can ask them to take a deep breath, and sometimes you can get indications of whether or not that inspiration is causing discomfort, whether it's shoulder tip pain, discomfort around the diaphragm, and you can also look for things like distension on the deep inspiration because it's putting more pressure on that abdominal cavity. From there, you can also look at the abdomen itself for general signs of bloating and distension. So if you imagine what a pregnant belly looks like, or has that perfect sort of glow and round shape, well, the same thing happens when there's abdominal distension caused by bloating or ascites or anything that is pressure within the abdominal cavity. You'll have these fixed lines as opposed to adipose tissue where somebody has fat pads growing on the exterior aspects. A trick you can do to note things like herniation or masses underneath the skin is as the patient is lying down, you can get them to tilt their head completely up to look behind themselves and then sit up and to look all the way down at their toes. So they just rotate the head all the way up and then all the way down. This will cause contractions of the abdominal muscles and you'll be able to find slight pops or distensions of hernias or even masses as well. You can also ask the person to cough, which increases the intra-abdominal pressure, which can cause discomfort. If it does cause discomfort, you're looking at some sort of peritonitis. You don't know what is actually the problem, but it's just an indication that there's an inflammatory problem within the abdominal cavity. If you're in a low light condition and you want to do a good examination, but you can't really look for distension, you can shine a torch over the top of the skin and look for shadows. So you obviously know where the natural contours of the abdomen is supposed to be. So sometimes shining a torch over the top, the light will travel over the surface of the skin And if there's a mass in a certain area, it will create a shadow behind it. Whilst this isn't a mandatory test all the time, sometimes it's a good trick that you can do if it's low light. From there, you obviously look at the abdominal region and you look for discoloration. You look for ecchymosis, you look for jaundice, that sort of thing. And in the event the complaint is pointing to more of an anal rectal disorder, then that's when you pull their pants down and have a look at the anal rectal area. You're looking for skin problems, you're looking for lumps, you're looking for prolapse, you're looking for any sort of hematoma in that anal rectal area as well. So that all comes under the inspection. You can also get the person to bear down pressure in order to look for those grade 3 rectal prolapses. As the person bears down, it will prolapse from the anus, and then as they stop bearing down, it will retract back into the cavity itself. Okay, that brings us to the end of inspection. Once you've done that, you note all your findings and you move on to auscultation. You always have to do auscultation before you touch the patient. So don't do any percussion or palpation before you do auscultation because you can get false positives. You playing around with the abdomen can actually increase peristalsis and therefore give you false indications of what you're listening to. So the best place to listen when you're dealing with auscultation is to use the diaphragm aspect. Some people think bell, but it's the diaphragm aspect of the stethoscope placed on the iliosacral area. Basically indicates the end of the small intestine and the start of the large intestine. So that's found in the right iliac area, basically in the corner of the umbilical and hypogastric region. So if you place the stethoscope there and you have a listen. Now, generally speaking, you should hear sounds within 30 seconds. Okay, so around the 30-second mark, you should at least hear one sound because normal bowel sounds is 2 to 5 every minute. So if you only hear one in that 30 seconds, then keep listening for the whole minute, see if you get the other, so then you can denote the difference between normal and hyperactive. If you don't hear any sounds at all, then you really need to listen for up to 5 minutes before you can say that there's absolute absence of bowel sounds. Okay, so just keep that in mind. So the fact that you didn't hear anything in 30 seconds does not mean that it's absent, and you should never write absence bowel sounds unless you've done the full 5 minute. And some papers recommend up to 30 minutes, so realistically, you're only going to suspect absence of bowel sounds and then refer them on. Hyperactive generally indicates some sort of obstruction. Now, this doesn't necessarily mean constipation. It just means that there's some sort of undigestible mass within the gastrointestinal system or the intestines, usually the small one, that is causing turmoil, causing extra movement, extra pressure, and the ability for you to hear those digestive sounds over the top. And hyperactive can be normal, particularly after sleep or in the presence of certain medication, but it could also mean something a little bit more sinister. So like the absence, it's quite difficult to define in a short period of time. You need to listen for an extended period, and it's best to refer them on so they can have proper examination outside of a clinic or the field. Once auscultation is finished, you don't have to put your stethoscope away because sometimes percussion can be enhanced with the stethoscope itself. So percussion is used to understand the general mass or the general tympany of the actual abdominal cavity. So generally speaking, it's best to percuss over all the regions of the abdomen just so you get an understanding of what is the general sound that is heard within that person's abdominal cavity, because everyone's that little bit different, and that's got to do with muscle tone, how much adipose tissue is there, presence of fluid. All these sorts of things will just detract or alter the sound that you hear on different people. It's always recommended that you practice your percussion on a whole range of different individuals so you can get an understanding of those different notes that you'll hear. If you hear a dull sound when it should be an air-filled sound, that can indicate that there's some sort of mass. Now that mass can be constipation or it can be some sort of cellular growth. There are a few specific tests that you can do with percussion enhanced by the actual stethoscope or without that can denote certain problems with the liver or the spleen. So whilst the liver can be palpated, and you've got things like the hook test and things similar done to the Murphy's, which we'll have a look at, sometimes, especially when you're starting off, the use of the liver span scratch test can be a little bit better for people that don't do percussion a lot. So the idea of the scratch test is you place the diaphragm of the stethoscope over the liver. Now that's basically the right upper quadrant of the abdominal area, and then you start above, so starting from the clavicle, and you just scratch. So it's not a wavy, tickly sort of thing. It is a scratching, moving across the surface of the skin. You can also tap as well. There's no real reason that you have to scratch, especially if it tickles the person. So you can tap, and what you're listening for is as it moves from the lungs, you'll hear it over the ribs, the sound will change, but then you'll get dull. And dull will start from when the top of the liver is present. And then you start down at the umbilicus, basically not on it, but in line with the midclavicular. And then you start scratching up until you feel the lower part of the liver. And that will tell you the liver span. Now, depending on the size of the person, the liver span can be anywhere between 8 and 12 centimeters. So if it is enlarged due to hepatomegaly, then it's going to be quite obvious. Now, you're not going to pick up subtle differences, okay, but if it is quite enlarged, then you will find that, and that's where auscultation and percussion can work hand in hand together. You can do a similar thing when you're dealing with your Castell sign, but that is generally done in the absence of the stethoscope, where you just percuss over the anterior line, left-hand side at the base of the ribs. So you percuss there, and then you get the person to breathe in and you percuss again. Now, a normal spleen will sound exactly the same. Normal spleen is far too small for you to hear it, but if you have splenomegaly, which can be denoted from trauma, but it's also a sign of Epstein-Barr virus as well. Okay, so you'll actually get a positive Castell sign on percussion in that region. And the sensitivity for that, specificity, is up around 83%. So there's even studies out there that suggest that it's more sensitive than ultrasound. Okay, so just keep that one in your back pocket. And whilst it's not regularly done in the primary healthcare space, if you're suspecting Epstein-Barr, it can be a great little test. The absence of it does not prove that it's not Epstein-Barr, but the presence of it really indicates that it's a bad infection with Epstein-Barr virus. Once percussion is done, we can finally move to palpation. Now, this is the most uncomfortable part for the patient, and it's best done with the patient with an empty bladder. So if you get the chance, get the patient to empty their bladder. If not, just take it into account. Don't put a lot of pressure over the bladder. You always start light, and you always start in the region that they're not complaining of pain. Okay, so start away from the pain and then move towards it. It's best to have a conversation with the patient, looking at their face, because even the most stoic individual can't really hide pain on their face, and it'll be a good indication. The patient may naturally want to put their hands above their head in order to get out of the way, but you need to not allow the patient to do this, because that will contract the abdominal muscles and blow your chest out. When you palpate, you want to palpate with just your fingertips, never your palms, and you want to move across all quadrants of the abdomen, and you're checking for tenderness and movements. Okay, things like air movements and crepitus, that sort of thing, can be felt along the abdomen, and any tenderness should be noted. Once you finish the light palpation, you'll have an indication of where the sensitive parts are. Now, if you need to go deeper, then you should only do it when you're actually suspecting that there's a problem, okay? Because going deep can be insightful, but a lot of the times it's mostly associated with doing specific tests. So if you think it's constipation, then you do deep palpation across the large intestines, moving up the descending colon. If you think that it's appendicitis, then obviously you feel for that. Okay, if you have pain felt in a region that doesn't make sense, and you can deep palpate over that area, but the idea is you want to go slowly. If you try to palpate quickly, then the body will naturally guard. Either voluntary or involuntary, the muscles will contract in order to protect that region. So just keep that into account. You want to almost build a relationship with the muscles as you slowly massage in, going deeper each time. Once you finish the general deep palpation, then we move to the specific tests. And there are a lot of special tests to go through. I think from reading, I found around 80 different special tests with different names that overlap and contradict sometimes. And pretty much there was a time period in the late 1800s all the way up to mid to late 19th century where every surgeon wanted to get their name on an actual sign to indicate some sort of pathological state. Now, the classic ones, and where you'll find a lot of individual tests for, is when you're looking for appendicitis. So McBurney's point is probably the most classic one, and it's used for the longest period of time as well. Now, McBurney himself was actually a bit of a mathematician, so he figured out a ratio compared to the umbilicus and the right iliac crest to where the appendix would actually sit. Now, that's been simplified from his original version down to 1/3, so the distance between the right iliac crest and the umbilicus, 1/3 from the iliac crest is McBurney's point. And you press there looking for rebound tenderness, and that is your classic finding for appendicitis. Now, this was fine-tuned, or a different sign, which was Rosling's sign, which is the same test but done on the opposite side. And you actually still get rebound tenderness on the right lower quadrant where the appendix is, but it's referred from the left-hand side. So that particular test really overlaps with your Blumber's sign, and Blumber's sign is a general rebound tenderness associated with peritonitis. So it all gets very confusing. And in modern times, McBurney's point and test has very low sensitivity to actual appendicitis itself. So they've moved on to other tests. So your psoas test, which is associated with your muscle, is done one of two ways. So you either hold the right leg down and get the person to try and lift it, therefore contracting the psoas muscle and causing pain over the top of the appendix that's inflamed. The other way to do it is to get the patient to lie on the left-hand side and then pull their leg back, straight leg back, stretching that muscle out with the same sort of indications. Sensitivity of that one is not very good as well, because you could have a problem with the psoas muscle. And therefore, if you test the psoas muscle, it's going to cause pain, false positive. So modern-ish, compared to all the rest of the tests, has come up with a heel drop jarring test. Now that has slightly better sensitivity, and that is simply done by getting the patient to hop up on their tippy toes and then somewhat violently drop down onto their heels. And it's the violent dropping of the heels that will vibrate all the way up, causing pain in the inflamed areas. So if it's felt in the right lower quadrant, it's more likely to be appendicitis. As you can see, a lot of these tests, they're not very sensitive. So the best thing you can do is when you are palpating and you're going that little bit deeper in the right lower quadrant or the left lower quadrant, if there's any indication of rebound tenderness, which is a start or an increase in pain as you release your hands, then you can move on to a psoas or a heel drop test to get better findings. But either way, it moves on for a blood test. You're talking about white blood cell count, indication for an infection, and sometimes even an ultrasound. The problem we often have in clinics and emergency departments is once someone gets a positive any one of these tests, everybody wants to have a play, and everyone wants to cause the discomfort for the patient over and over and over again. And with appendicitis, if you constantly do McBurney's points, you can actually aggravate the appendix to the point that it can, in fact, rupture or cause leakage into the bowel, causing greater inflammation. So just be aware that constant McBurney's tests, or constant any of these tests, really, will actually increase the discomfort to the patient. So it's best to do as an indication and then move on to your more sensitive tests. The other one we'll look at is a little bit controversial, and it's got to do with the gallbladder. So this is a test for cholecystitis. Now, cholecystitis is also an overlap with cholelaiasis. So you can have cholecystitis without stones, but you can't have stones without inflammation. So either way, this is just an indication. Now, Murphy is the one that's got all the credit for this particular test, but Murphy's original sign was actually a little bit barbaric, and it was actually done after Nyan sign. So Nyan sign first came out in 1896, and that's more your classic Murphy's sign, which is denoted by the picture. Okay, so if you ever learned Murphy's sign, you probably actually have learned Nyan sign, and Murphy's sign was originally done by standing behind the patient when they were sitting up, and you'd actually hook your fingers right underneath the rib cage and stick your fingers on the gallbladder and then get them to breathe in. The other way to do it supine was to turn your fingers into like a chisel, for lack of a better term, and then hit the top of your hand down, so you'd actually go in and basically punch the gallbladder, causing a mass discomfort. So that was Murphy's sign, and yet he gets all the credit for the actual test. So the test, the way we do it now, is placing your fingertips underneath the rib cage as far as you can, slowly and as gently as possible, and then get the person to breathe in. As they breathe in, the gallbladder will come down and press on your fingers, causing an increase in discomfort. Makes sense? Now, unfortunately, this can actually make the patient quite nauseated because you're pushing on the gallbladder, responsible for releasing bile, and it can be uncomfortable for the patient. So again, you only want to do it once or twice as a confirmative, and then move on to your actual more sensitive test. Now, Moynihan sign, it did come out, and it was one of those ones that was looking after the patient, where you would just place your hand on the rib and then push your thumb up. Now, whilst it sounds a lot nicer than Nyan sign, it's not really deep enough to have any sensitivity associated with it. So it was somewhat discredited pretty early. So the greatest sensitivity that you'll find is with Nyan sign, which luckily is traditionally the way Murphy's sign is taught. On top of that, there are a huge array of other signs you can find. Now, this list is a very limited list, and if you want to go on and look, you will find heaps. A little project for you to write a study guide if you want on all the different signs out there. But the bottom line is it's all got to do with some sort of referred pain, rebound tenderness, or pain on palpation when you're dealing with the palpation signs, or it's got to do with findings of ecchymosis in certain areas denoted by Cullen's and Gray-Turner sign, which is hemorrhage, pancreatitis, or AAA. You'll find a massive overlap of appendicitis being very, very common. There'll be a lot out there that want to put their name to it. Whatever one you choose, it's often good to have a primary one that you're going to find anyway as part of the examination, like your Rosig or McBurney, and then a more sensitive one like your psoas versus your drop test, in order to have those double positives, more leaning to appendicitis before moving them on. Nyan sign, which is denoted as Murphy's sign, is quite a sensitive test for cholecystitis, and Kerr sign is quite a scary sign. It's got to do with left shoulder tip pain, got to do with irritation of the diaphragm associated with ruptured spleen or a ruptured ectopic pregnancy. So it's not a bad one to look into as well. All right, that brings us to the end of abdominal examination. From here, it is highly recommended that you go on and you practice this abdominal examination. Get someone who's been playing the game a little bit longer to go through a few of the findings and practice on patients that don't need it, or practice on patients that are not really sick. They've come in, they've got complaints, do a proper abdominal examination, looking for all the things that you could find in someone that is more acutely ill. Obviously, you always get consent. Patients aren't our training aids, but most of the time, patients are more than willing to assist in improving your clinical understanding. But until next time, take care.